Good afternoon, everybody. Welcome to this webinar. Thank you so much for joining. It is absolutely fantastic to see the very significant number of people who are joining from all over the country. So welcome if you are joining from Newcastle, if you're joining from Newquay, if you're dialing in from local government, from a hospital, from a GP practice, from whatever part of the health and social care system you come from. Thank you very much for giving us your time at this very, very busy moment for the health and social care system. Your contributions, your ideas are deeply valued, and thank you very much for joining us. This is my name is Roger Davidson. I work at NHS England Improvement on the important mission of integrated care. And this is the first of a series of webinars on trying to support people on the delivery of integrated care around the country that we are launching that we are carrying out in partnership with the Social Care Institute for Excellence. When we looked at the question of what topics we should cover, the topic of relationships seemed to us to be deeply important. Every single time I hear anybody talk about the delivery of integrated care, one of the points they make is that relationships are absolutely key. And yet we probably don't spend enough time thinking about how to really go about that and how to make a success of that. And some people say that this is kind of the soft stuff. This isn't this is all a bit fluffy. But actually, I think as we've learned over the last 2 or 3 years working on the integrated care journey, it isn't the soft stuff, because this is about creating a purpose that everybody believes in. It's about having the rules of the partnership, the rules of the game clear. It's about spending time to understanding each other. And it's about delivery and making sure that everybody can see delivery in order to build trusting relationships across the system. And I'm really, really pleased that we've got 3 of the pioneers of this from around the country with different perspectives on this particular question, both to give us their take, their experience, and also to answer your questions and respond to the points that you want to make. So I'm just going to ask those people to introduce themselves. Rob Webster, I'm sitting in London, by the way. Rob Webster, I think you're in Wakefield. Could you just introduce yourself?
Hello everybody, my name's Rob Webster. I lead the West Yorkshire and Harrogate, and I'm in Leeds today.
Okay, hopefully everybody caught that. Can I ask Paul Burstow to introduce himself?
Hi, I'm Paul Burstow. I'm the chair of the Social Care Institute for Excellence, but I think I'm here today really to talk wearing my hat as independent chair of the Hertfordshire and West Essex STP.
And can I invite Dr. Gemma Moore in Worcester to introduce herself?
Hello everybody, my name's Gemma Moore. I am a budding GP, so I've just been dealing with the coronavirus disaster plans this morning whilst I was duty doctor, and I'm delighted to be here today to talk to you in my role as Clinical Director for Droitwich and Lombersley and the Strategy Director for SW Healthcare, which is a GP federation covering 32 practices.
Fantastic. So we've got 3 really different perspectives here. We've got Rob. Rob was the leading one of the systems that was one of the pioneer integrated care systems 2 to 3 years into their journey. Paul leading on a system that is hopefully just about to become an integrated care system and working through the issues there. And Gemma, who can talk to us about building multidisciplinary teams across a locality. So really welcome to all 3 of you. And the way we're going to do this is we're going to invite our 3 contributors to say a few words, and I'm going to be looking at the chat box and trying to make sure that you're all engaged. I might be sort of saying 1 or 2 things as people talk, so it's not too it's sort of just so it's kind of like interactive. and then we'll come to a session where we'll have, so hopefully 20, 25 minutes or so just to get questions. So really do contribute, get your ideas in there, get that chat box moving, and tell us what you think and what questions you want to ask, and I'll do my best to reflect that. So can I kick off then? Can I invite Rob Webster to tell us his experience from the West Yorkshire and Harrogate perspective?
Thanks very much, Roger. Can I just check that people can hear me okay? I think there was a bit of a problem earlier on. Yeah, okay, so I'm getting thumbs up from the team. So, morning everybody, I'm going to give you a bit of a flavour of some of the things that we've been doing in West Yorkshire and Harrogate over the last 4 years. If we start, if we want to move on to the next slide, I'll just probably spend a moment locating where West Yorkshire and Harrogate is for those people around the country. We're one of the biggest health and care partnerships, and it's quite complicated. So we have 4 community and mental health trusts, 8 councils, 6 acute trusts, and hundreds of GP practices, third sector organisations, and care homes. And critically, when you look at that complexity, what we need to do is to make sure that we have a way of working together which ensures that, can I just check? So we're getting a lot of sound issues still on the chat.
Don't worry about that, Rod.
Okay.
It's being sorted out in the background.
Okay, cool. So we've got a complicated system, and I think one of the things that's really important is to ensure that we have an understanding of the challenges we face, but the opportunities that we have too. If you want to move on to the next slide, I think that we're all aware of the kind of things that make collaboration in the current context challenging, and whether it's the regulators focusing on individual organisations, the differences traditionally in a top-down NHS management style versus a democratically accountable local authority, or the fact that funding works in different ways in different places. We know that there are challenges to address. However, we can overcome them if we put some things in place. And that's what we've been working on over the last few years. So if you move to the next slide. When I started in this role in 2016, one of the things that I was keen to focus on was who did I know locally, and how could we work together on the things that would jointly make a difference. One of the things which really, which Roger alluded to earlier, is that I think people have recognised that relationships and the power of relationships are fundamental ingredients to the success of collaboration and to the success of public policy. And Julia Unwin, who's a Carnegie Fellow and used to be president of the Roundtree Foundation, has done a really fantastic paper on this, which I'd recommend to everybody, which talks about kindness, emotions, and human relationships, and policy. What that does, it draws out one of the things we're pathological about, which is being rational. So we want things to be fair, to be open, to be equitable, and to be having an impact. So we have good rules, but we find that things aren't fair, things aren't rational, and things aren't equitable, because what we haven't done is focus on relationships, which bring hope, a bit of dynamism, some discretion in terms of effort, and some challenge to the status quo. So we focus very much, and I've always focused on, are our relationships big enough to ensure that we can deliver the things that we need? And as an integrated care system that's very complicated, we started from the position of how do we know each other? If you want to move to the next. One of the things that I learned a long time ago was that however complicated things are and however difficult they are, you can have a common point of agreement. And this is a picture of Senator George Mitchell. He was involved in the Northern Ireland peace process And one of the things that he did, which made it a success, was to ask both sides before they began the conversation and the talks to come to the talks with one thing that they agreed that they wanted together. And the thing that they agreed on was that they wanted peace for their children. Now, what we've always worked on is what's our equivalent of that? What is it that we will always go to, which will allow us to ensure that we can always work together? Want to move on? Next slide. So we started off by talking about, as an integrated care system that covers a broad geography, 2.6 million people, and spends £5.5 billion together, what guiding principles do we have which will shape the way? And these were crafted 4 years ago, and we still talk about them at every meeting. So we're ambitious for the populations we serve and the staff we employ. This is a true partnership of local government, the NHS, commissioners, providers and communities. We do the work once, so that we don't introduce a load of extra governance and meetings. We always undertake a shared analysis of problems and issues on the basis of taking action. We don't have to agree 100% on the action, because consensus is and importantly, subsidiarity principles apply. So the work always gets done as close to the individual as possible. And in doing these things, in having these guiding principles of how we work together, we're very clear that what we want to achieve is improved outcomes for people, reductions in health inequalities, improvements in unwarranted care variation, and managing our £5.5 billion. Now that stood us in pretty good stead, and alongside that set of principles, we've then built on a range of things that we want to do. So it's important, as you are beginning to develop trust and an agreed action plan, that you have an agreed vision of where you want to get to, one that's simple to describe and that people want to achieve. That you have a set of principles about how you work, and then you put them into action. So in 2016, we published a plan. In 2018, we published another, because we wanted the public to see what we were doing with their resources and the difference that we could make. In the interest of time, I won't go into that too much, but if you look at the progress that we've made, I would say that it's been substantial. It's been substantial in terms of reconfiguration. So we've closed hyperacute stroke services which were inefficient. We've improved stroke care across the board as a result. We've managed collectively to get £883 million of capital investment for 10 schemes, from brand new hospitals and child and adolescent units to new pathology services. We've set up award-winning services to support carers. We're working on how the arts support people to be healthy and well in communities, and so on. So we've been incredibly successful as a partnership. We've managed our money together, and we've delivered a single control total, backed by all of our providers being on aligned contracts. All of that's done through a true partnership. So third sector is a key partner on all of our governance arrangements. The NHS is a key partner, local government's a key partner. We have real people sitting on our partnership board, which governs everything, and we try and ensure that all of our conversations focus on the right issues and the right impact. One of the things that we've done throughout this process is to make sure that we're testing and challenging each other about whether we're really working in this way. And we do that at neighbourhood level, we do that in each of our 6 places, and we do that across West Yorkshire. One of the people who's helped us is a guy called Myron Rogers, who deals in post-conflict situations. And we might consider that the health and care system is in conflict. Sometimes it is, but there's a lot of lessons that he's taught us. Now, one of the lessons that he taught us was that real change happens in real work, and building trust is often about the impact. So if you move to the a couple of slides on, if you ever go on our website, you can see case studies of the real difference that we're making in each of our communities on the things that really matter to local people. Because we're not here just to have meetings, we're here to make a difference. We're here to save lives, we're here to create a better environment, we're here to build aspirations for our workforce and for the people that we serve.
Okay, Rob, I'm going to, if I can just interrupt you there, because we've got a few issues with sound, which we're just going to try and address, and I'm going to come back to you in a few moments. But I'm just going to invite Paul Busstow to come in now and do some of his perspective. Forgive me for doing that, Rob. I want to some of the sound problems we've got, which we'll try and address.
Yeah. So whilst we're working on that, I'll just say a few things, go through some of my slides. So again, like Rob, this has been a journey, and I'm on the journey more as a non-executive rather than an executive leader within the system, and that's an interesting experience as well. So let me just, I think what I'm going to try and do is say a little bit about my role here at SCIE, and then I'm going to say a little bit about my work at Hertfordshire and West Essex, where I'm the independent chair. So this is just a slide that says a little bit about my background, 30 years of involvement in public services in one way or another, councillor, minister, parliamentarian, and since 2015 I've taken up a variety of non-executive leadership roles in the NHS and in social care, and I think really sort of issues around well-being, ageing, resilience, co-design have been the sort of core things that I'm interested in and have been working on. So let's go on to the next slide. Just say something really about the Social Care Institute for Excellence, which I chair. We're a charity. We were set up in 2001 rather, and we have really a number of roles. But we work with the Department of Health and Social Care, but we also work as a partner with a wide range of organisations in the public sector, in local government, in the NHS, and also, in fact, into the wider sort of charity sector and faith communities, particularly on our work in safeguarding. I would say there are three things that stand out about the role of SCIE. One, we promote excellence and innovation in social care. Secondly, we put lived experience very much at the heart of all that we do in the way that we do it, and that we act as a partner with clients to take them on and work with them on a journey to improve what they're trying to do in the way they deliver social care. And that particularly includes areas like integration. So going on to the next slide, this is really just to flag one of the many pages on our website, and we've got a wealth of expertise, resources, tools really to support systems and people and places make a sense of this integration journey, really right down to the individual multidisciplinary team, but also right up to systems leadership. And this is just one of the pages on our website that sort of help people think about and tap into the resources that we have. A couple of examples of the resources, next slide. This is a publication that we produced jointly with the Local Government Association just a little while ago now. We were asked by them to look at the evidence of what the high impact interventions and actions would be around integration, and we've identified 15 of those. This is a couple of quotes on this slide which really just highlight some of the wisdom that we garnered from talking to a variety of people that are on this journey to integrate health, social care and bring partners together. And I think the one I would take first is the comment really that integration isn't an end in itself. It's really a means to an end, and that's about how the individual citizen and their family experience the care that is put around them to enable them to maintain their independence and have a good quality of life. Moving on to the next slide. Another piece of work that we've been doing with the NHS Leadership Academy is some work really around what are the markers of system leadership. And I think a quote, from, in fact, David Pearson, the ICS lead and now the independent chair for Nottingham's system, he made this point that system leaders probably spent 10 to 20% of their time on partnership activity a decade ago, and now it's maybe as much as half of their focus is effectively on those collective aims. And I'll say a bit more about that in a moment as well. Moving on to the next slide. Really, this is just to start to say a little bit about the partnership in Hertfordshire and West Essex. We cover a population of about 1.5 million people, got a very large number of GPs. We have 3 clinical commissioning groups, 2 health and wellbeing boards, the Essex and Hertfordshire ones, 13 district councils, and many other organisations, 3 acutes, a number of community providers, and so on. So it's a big geography. It's a geography just north of London. It's an easy geography to navigate up and down. It's much harder moving across it. And anyone who works in the patch will know that only too well. Moving on to the next slide. I think really just to say a bit about my appointment as a chair. The Sustainability and Transformation Partnership, like all of them across the country, was set up in 2016. And I think really they had been working together as a system over that 2-year period before I was appointed in December of 2018, trying to work out how they would work differently and how they would work together. And the sort of phrase that was often used by people when I spoke to them when I arrived was a sense of sort of Groundhog Day, that they kept on going round the same issues multiple times, but never actually quite getting to the point where they could take the next step. In other words, I think there wasn't enough trust and strong enough relationships to do that. The brief that I was given by the system, by the chairs, non-executives, the executives and others within the system, really set out on this slide. And I think one of the things I found very useful about being given a very clear brief in the appointment process was that it gave me a very clear mandate and a very clear sort of ability to be able to say to colleagues, well, you've appointed me to take this role to help work with you to navigate us all to an agreed outcome in terms of creating an integrated care system and a number of place-based partnerships across our area. Moving on to my next slide, I think the thing that also struck me very early on was very much the sort of language that people used to describe the Sustainability and Transformation Partnership. I spent a lot of time, the first 3-4 months, out and about across the Hertfordshire and West Essex area, talking to chairs of boards, talking to people in the voluntary sector, talking to local government colleagues, both councillors and officers, really just trying to get a sense of what the issues were, what people thought about the SDP, what they hoped the SDP and ultimately becoming an integrated care system could be all about. And I think after a lot of listening and some gentle probing to try and find out what the appetite for progress really was, I was heartened to find that actually people did absolutely get the benefit of joining up and integrating care, but there was still quite a lot of othering of the SDP, of seeing it as something that was not part of what their day job was all about. So one of the things, and just I'm going to ask my colleague to click the slide again, it'll make the point that we needed to move from a them and us situation to an us situation. In other words, we had to own our SDP, not see it as an SDP being imposed upon us as all the different actors in the local system. I think once we began to get that language of how we talked about ourselves, that made a difference. And I think there were really 3 or 4 things that particularly I would say are key to this whole piece around trust and relationships. Trust takes time. It takes a lot of talking, but more importantly than talking, it takes a lot of listening. And also it takes a lot of doing. Actually doing things together and beginning to work out different ways of doing things in your area is a very key part of actually evidencing and building that trust. Moving on to my next slide, I also found that when it came to explaining the why of forming an integrated care system, that in a way the why had been lost. The why had been lost under very, very large numbers of priorities that have been established, all in themselves perfectly good goals for the system. There were 60 or more projects that were running within the system. And some were really taking place, others were things that people felt we should be doing. But in a way, all those priorities meant that nothing was a priority. So we spent quite a bit of time as a leadership group within the system working out what our top 3 or 4 priorities were as enablers to driving the development of our system, and in terms of our key care and clinical priorities. Things like workforce, technology, money, getting population health management off the ground, addressing issues around frailty in children. Some of the examples of the things we managed to boil down our priorities to be our focuses.
Paul, can I just come in there on one thing? I've just seen this kind of point coming up in the chat box. Because obviously you've got the work that you do as a senior leadership group to establish that common purpose and the development you do as that. How hard is it to get onto the wider leadership community and the clinicians and other care staff kind of right across quite a big significant system?
It's not easy. I think one of the ways in which we've done this is through the various work streams that I've just described. There's an opportunity through them working with clinicians, working people from the voluntary sector, people at all levels of leadership within the system together. That is a regular opportunity to sort of communicate what this whole endeavour is about. And I think probably the other thing we've recognised is that there are whole layers of leadership within the NHS, within our local government partners as well, and we need to bring them together more routinely. So we've established a organisational development partnership, which is going to have events on a regular basis, bringing together leaders from all those different parts of the system to work on common challenges and problems.
Great, thank you.
Next slide was just to make the point, possibly the overlap, and click again. Just a sort of final point, really. Thank you. There are probably 2 big things that make me get up to be involved in an integrated care system. The things that motivate me, and I think increasingly are the glue that is bringing everyone together in this endeavour. And they are a desire to tackle health inequalities and a desire to improve the overall health of the population. In other words, to be curious about what's going on beyond the boundaries of your own institution and be interested in what you can do as an institution to change that. And this slide is just based on some work by the Health Foundation. It's a national graph, but it shows actually, in terms of healthy life expectancy and the quality of life that people have, there's a 25-year health gap in this country. It's not as big as that in Hertfordshire and West Essex, but it's still big, and you can have within a matter of a few miles a 9 or 10-year difference in life expectancy. So we have some real issues to be challenging. And I think that is becoming a guiding star for the way in which we have our conversations and bring ourselves back to what our sense of purpose and ambition actually are. And I think that is, if we can move on to the next slide, reinforced by some of the things that were in the long-term plan that was published at the beginning of last year. And I have to say, I found when the plan was published in January of 2019, it was very helpful, because what it made system leaders in the NHS realise was that this drive towards integrated care systems as being the way in which we were going to work in the future and the sort of operating model of the future, it helped reinforce that direction of travel. And I guess I just put this up to sort of reinforce the fact that health equity, population health were really part of the sort of goals of the long-term plan. Moving on to my next slide, I think probably one of the things that I took away from a number of discussions I had with people around the country who were leading the development of integrated care systems was you need to focus on the relationships, you also need to focus on the money, and then the governance piece is possibly the last thing you really worry away at. So I wanted to say something about the money, because I think one of the breakthroughs for us as a system in Hertfordshire and West Essex has been the conversations we've been having amongst our community of finance directors, but both commissioners and providers and local authorities, about challenges around the money. And we have a very good SDP finance director who's got the right temperament, I think, to have garnered the respect, the trust, and active participation of all of the FDs in our system. And I think that's helped us get a lot done. So just an example, we now have 2 of our acutes. They have signed up to minimum income guarantee contracts. That means they're no longer being paid for activity. They're being paid for an overall amount of resource to deliver a more comprehensive range of services. And it has freed up some of the sort of bandwidth that in the past was taken up in arguing over whether the numbers that the commissioner, the CCG, thought were the right numbers and the numbers that the provider thought were the right numbers, in order to try and get an agreement about what the actual bill that was going to be paid. And that's freed up a lot of capacity and time. And just going on to my next slide, if I may, why does that matter? Why does that change of relationships between finance directors matter? Well, it matters because one of the things that the NHS has said to systems is that in this year that's about to start, the way in which some of the money is going to be allocated is going to be on the basis no longer of just how individual organisations perform, but half of it is going to be determined on the basis of how the system has financially performed. So you could be an organisation that's jogging along perfectly okay, delivering the goods in terms of services and balancing your books, but another organisation may not do that, and there will be consequences because some of the money will be tied to the way in which the overall system is performing. So this money is the money that helps balance the NHS books, and I think it's going to help concentrate minds even more. It creates an incentive to think differently and act differently, and understand that we all have to be mutually accountable to one another. Moving on to my next slide, I think that one of the interesting challenges about bringing this new idea of integrated care systems into reality, to make it something that is lived and real to those that are involved in them, is to understand that we're on a journey of unlearning. We're unlearning 30 years of how the NHS has been run, which has largely been a marketplace of individual organisations encouraged to actively compete with one another. That's not what the new approach, the new way of working is all about. And if my colleague clicks the mouse again, the point will hopefully become clear, because what I'm trying to say, and what I find is very helpful and powerful in the conversations I have with colleagues in Hertfordshire and West Essex, is that we're creating an ecosystem that is all about people. And indeed, what we hear when we did our Health Watch survey to help us inform our local plan, what people said to us was that I'd like my healthcare to focus more on my wellness than my illness. And I think what people who've been chief executives within hospital trusts, within community trusts, chief executives of local authorities, wanted to be assured about was that we were not building some large new organisation that was going to be a competitor to what they did. But actually what we were creating was a way in which they all could work differently together, and that the focus really of our energy was on how we built new, really effective ways of delivering health and care at a place level and integrated care partnerships. And one of the things that I think comes across for me in all of that work was really that my role in all of this was very much to help people stay focused on the common purpose that was motivating us all, and that the ICS really was there as the vehicle for that, not a new organisation.
On that point, Paul, a lot of the questions I think are centering around the kind of practicalities of all of this. So that I'm getting I think hopefully I'm summarising this accurately just looking through the chat box, but it sort of feels like people get the principles, but they've got practical things in the way, which might range from IT, it might range from having the time, and it might range from the competing priorities of the different departments and organisations within the system. Any thoughts on for the people who are kind of in the middle of all this and will be experiencing those conflicting pressures? Any thoughts for them? I appreciate you can't answer all that in one kind.
No, but it's absolutely. And I mean, I think one of the things that often is said to me is that this feels as though it's something on top of the day job, and I think the thing that we have to do increasingly is change the nature of the day job, because the day job is about how we deliver great care that wraps around the individual, that involves the individual in being able to help direct that care, and also gives them more sense of control over what's being done. And I think that sort of integration is ultimately what we're trying to achieve here. And I would say in the conversations that I have with chief executives and other leaders in the system, the thing that is most important is that we are constantly making sure we don't overstretch and overreach. I think that's what I would say is most critical to this. And a good example would be technology. Individual organisations can't solve the sort of technology challenges that we're going to need to solve and resolve to create the integrated working, to make sure that an individual turning up in any part of the system will have the information on hand that will help them get the right treatment in the right way at the right time. And therefore having a common sense of what the agenda is for your investment in technology, rather than simply an institutional view about your investment strategy, is likely to mean that you spend the money well and you don't wind up then having to do workarounds later.
Can we just attempt to go back to Rob Webster, who I believe has changed headsets, and hopefully that will mean that we're able to. Everyone, I know some people on the app had pretty good sound, I believe, but I know some people didn't. Rob, any kind of? I'm sorry to cut off your previous presentation slightly short, but did you want to sort of come in back now and pick up a little bit?
I just was going to reflect a couple of things that Paul had said. So I think Paul's points about the system. One of the things I often point out to my colleagues and to everybody else is that the integrated care system is a system. The clue's in the title, and it's not an organisation and never will be, because the partnership that we've created through local government, the NHS, community organisations, third sector, and the private sector is a true partnership. And one of the ways that you build trust and confidence, I think, in the system is alongside your common point of agreement about what you're trying to deliver, alongside the way you're going to behave, is to focus on the things that you want the system to do for you. So as a partnership, the West Yorkshire and Harrogate Health and Care Partnership belongs to the partners. It's not their boss. It can only get power from the things that are ceded to it by the trusts, the councils, and the community organisations within it. It gets its money from them. It gets its power from them. It focuses on the things that matter to them. So I think one of the first things to do is to invert this sense of power, so that rather than creating an additional layer in the system that's going to boss everybody around, what we've created is a servant of the partners which will do things on their behalf, like reconfigure stroke services so they work for everybody. Focus on how you help 260,000 working carers, informal carers, so that they get the support they need, so that the health and care system can work. So I think that's a really important thing for us to hold on to when creating this trust, is to understand that the power dynamics here are about the system working on behalf of the partners. The partners are the constituent organisations. They give the system the power and authority to do things on their behalf that can only be done at that level.
And Rob, can I ask you a question?
Yeah.
One of the things that impresses, I think, about West Yorkshire Harrogate is that kind of clarity of purpose that you have, and I know not you just believe in, but all of your leaders believe in. You've got a really clear set of rules, as you were saying earlier, about how the partnership works. And I think everybody would sign up to that. So, yeah, that sounds great, but how do you achieve that in a really? And I know that West Yorkshire Harrogate is not a simple system either. But how have you really done that in your area? I don't know if it's possible to give us a bit of a flavour of what you did to actually achieve those kind of agreement between all parties as to how to function.
Well, I think so. You have to work at it, and you tend to it all of the time. And if you stop tending to it, then it will collapse. I think it's really important that we recognise that the soft stuff, I think, as Paul said, is the hard stuff. And you've got to work at the relationships, the common points of agreement, and you've got to start showing that it matters. And we've done that, I think, starting with personal relationships and some very high-level points of agreement, and then quickly moved on to saying, okay, then we'll only work at this level, if we pass one of 3 tests. So we've got a scale issue. The example I tend to use is if you want a hand transplant, you can have one. You have it in Leeds because they're very rare, and that's the only place that can do it. You don't have it at Calderdale Royal. So it's a scale issue. It's a wicked issue. How do we deal with childhood obesity in the 21st century, for example? Or it's a good practice issue. Somebody's worked out how you do something, let's all copy. So on the basis that you've got some high-level principles that you've all agreed on, you've got some personal relationships that you've tended to, you've agreed on a set of priorities, and you demonstrably start to focus on them and make a difference, it builds trust and confidence. And then I think the point that Paul made about money is another brilliant example. So we all know what's really going on with the money. So I'll let that land for a second. We all know which systems or organisations are financially distressed and which ones we believe are signing up to control totals they'll find it difficult to deliver on the basis they want to get as much PSF as possible partway through the year, and then it will all get risky towards the end of the year. They won't get the last bit, but at least they've got some money. So because we all understand that in the system or have a suspicion about it, we got into an honest conversation about saying, why don't we change the conversation about how much risk people are carrying, and then let's look at how do we support people who are carrying greater risk, not worry too much about whether people are signing up to a control total or not, what degree of financial risk they've got. Let's be very open about it, and let's try and help each other. And once we start to have the honest conversation about what's really going on, that we could have because we'd had some OD support, I think you start to get to a much better place. And being honest with each other is much easier than pretending.
That's really helpful. I love the quote, the soft stuff is the hard stuff. Or do you want to sort of come in? So I sort of cut you off a little bit there, and then we'll come to
the last couple of comments, I think, really. I'm just really reflecting on a few of the comments that have been made by people listening to our conversation so far. One, I think, is a question about the extent to which integrated care systems are not just the creation of public sector organisations. They have to be able to engage as equal partners with the voluntary sector. And I think, Rob, you're doing some interesting stuff in that space, and I'm very clear that one of the next steps for Hertfordshire and West Essex is to start to really create the context in which the voluntary sector is not just there as a servant of the system, but actually there as a partner in deciding its priorities and shaping its future. And the reason for that, for me, is that the voluntary sector often have the appetite to innovate and a closeness to citizens that sometimes escapes other parts of the system. So it for me is an absolutely key challenge. And I think the other thing I heard, saw a number of comments on, was anxieties about what this means for me and the job that I do today. And I think that's a particular, concern, possibly within clinical commissioning groups. I certainly hear it there, and I think that's partly a function of the fact we are seeing a wave of mergers of CCGs, and that does cause anxieties. And I think we have to be open and honest about that and make sure there's good HR practice all around that. But actually, as Rob has rightly said, this is not about sort of past agendas of forcing mergers of organisations or anything like that. It's about getting organisations to think about the interests of the patients they are serving, why they're there in the first place, and what more we can do together to actually minimise the numbers of people who get ill or have long-term health conditions that are not well managed. How we support people to live well in that sense is, for me, one of the exciting opportunities of this. And actually, we're going to need more people in those sorts of roles, not less.
Can I thank you? Can I try and just bring in Dr. Gemma Moore, who is I was just saying earlier, was the clinical director of the Droitwich and Ombudsman Primary Care Network, and then is in Worcestershire. How does this all feel from your perspective, Gemma, and your experience of really making integration a reality for patients in a community?
Oh, thank you. I would agree. I think it's a really difficult journey when we start on the integration pathway, and it all does rely on communications and relationships. But I think it's really exciting from a GP perspective, but equally it's really scary for primary care colleagues. We're facing workforce issues, finance issues, lack of autonomy, lack of flexibility. There's all these things that just make it difficult. But I actually think the key to it is if you focus on sustainability and focus on your population, what are your issues within your area? What would get everybody home half an hour a day easy, quicker, and what would really matter to the patients that you're looking after? And I think when you start to think about some of those things and put some practical things into place, then you can really start to achieve things within your local area that will ultimately influence the STP and how it works going forward. So we're very much focusing as a group of 4 practices on care homes, obviously a big topic with the new national PCN DES that's come out, and we really want to have a look at what level of care do those patients need, how can we improve care for those patients, and how can we reduce the GP workload with that particular group of patients. So we're starting to look at a joint community model that's brought together health and social care, GP colleagues, and everybody that would be needed to look after a care home team, to have a look at what does that care look like and what does it deliver. And for us, it's one of the true parts of integration that have really happened locally, because everybody's come forward with equal finances, equal playing field to say, well, what do we need to do? So we're starting to see good tangible outcomes, very practical.
Can I ask you about the question of equating unified clinical teams and like sort of across so medical GPs, nursing, therapists, social care, voluntary sector? You know, what's your experience of that? Has that been a tough thing to do, or is everybody jumping at the bit to work together? What's your experience?
I think on a practical level, because everybody's struggling and people can't workforce problems, people want to do it. It comes down to financial constraints, I think. But what we've tried to do is put the budgets together so we can start to deliver this. So we've stopped looking at pockets of money in silos and looking at, well, what does a care home team look like, or what does an integrated community team look like, and what finances can we put into that? So what GP resource can we put in, what social care resource can we put in, what healthcare resource can we put in? And then we've started to look at the pots of funding and then build the service around the funding, rather than people saying, that's my money to deliver X part of the system. We've tried to break down the system and actually look at what does a system need to deliver. So
and we can feel, we can feel the tension that you've got there between literally dealing with the patients who are coming through the door and this big transformation. I mean, it must be very difficult to find the time to ride all the 2 horses at the same time.
It is difficult, but it is really interesting. It's really exciting times, and actually, if we don't address this now, we won't have the integrated future that we need. So I can see that the only way I'm going to provide more patient care and provide a better level of patient care to the patients is if we can sort some of the system problems out. Because when I ring the district nurses and they tell me they're too busy or they can't go and manage this for a number of days, we need to work through those problems together so that the whole system benefits to provide the care for the patients. If we look at it in silos, I don't feel we'll get there.
Sure. Okay. All right. So can I just ask the all members of the panel to think about some of your kind of what having sort of gone through this conversation, what you think some of the key points are. We've got a bit of sound noise on there. Somebody needs to go on mute if that's all right. But to think about, because we've had a really good conversation here about, as Rob was saying, the soft stuff is the hard stuff. The importance of having a really clear kind of common purpose, of being aware of the practical issues that get in the way, aware of the pressures that are on individual teams as they try to both deal with the service users and patients who are coming through the door, as well as do transformation. Any sort of thoughts on drawing all of this conversation together? Can I invite Rob for you to give us some thoughts on that?
I think I thought Gemma said quite beautifully, there's a lot of opportunity in this. And the first real opportunity is to recognise that the challenge we face today is that most of the people we work with will never be cured of the issues that we've got. they're suffering from long-term conditions, dementia, enduring mental illness. They may have a learning disability. So we're a partner in their health and care, and we're a guest in their lives. And that means that we need to join up care around their needs. That requires place-based planning across the medium term that looks at have they got somewhere to live, someone to love and something to do, and if they need health and care support, is it joined up? It's as simple and as complicated as that. And I think having an approach through an integrated care system, which looks at place-based planning in the medium term, the determinants of health and joint health care, is a brilliant job to do. And it is the job that's in front of us. We have to move away from solely focusing on episodic care. Episodic care is really important when you need it. It's not everything. And I think we've got a fantastic opportunity to do something really quite wonderful with the work that we're doing. So I think that's the first thing.
Well, one of the things that's come over listening to all three of you talking about this, and also I have to say looking at the chat box as well, is the values of the people involved, and values is a very important part of because we've got a lot of humps in the road to get over here, haven't we? So people have to really believe in this. How important are values and behaviours and Paul in terms of making a reality of this and taking everyone on the journey?
Yeah, I mean, I think a couple of the principles we sort of agreed quite early on to sort of try and inform the way we were going to behave with one another was that we should always talk positively of one another, and secondly that we should be able and willing to walk in each other's shoes. In other words, try and think ourselves into the perspective of others, and those two things help an awful lot in the sort of discussions we're trying to have. I think probably the thing I did want to say was probably one of the best, most animated discussions we've had as a group of chief executives, chairs, and sort of system leaders in our system was around a presentation that we'd had from one of the county councils about economic development. And the whole sort of discussion became one about how the NHS could play a much bigger part in both informing and influencing not just the short-term day-to-day business of delivering healthcare, but actually what the future of health and healthcare would look like for the county of Hertfordshire and into Essex. And it was one of the really interesting discussions we had. And one of the things it opened up was a sort of recognition that all of the partners cast very big shadows. They have very big footprints themselves as employers, as supply chain purchasers, as owners of lots of buildings. And that very often we don't think about those assets that we hold and how big an impact they have either for good or for ill when it comes to the wider impact on our population's health. So I think we are beginning to have really quite an exciting dialogue about those things, because we think in the long run, by addressing those sorts of issues, those wider determinants that Rob's been talking about, we begin to really begin this bending this demand curve and actually resulting in better quality of life for people.
I wanted to ask you, Paul, about the relationship between the NHS and local government, because somebody mentioned earlier in this discussion the 2016 start of the STP journey. It got very lots of tensions were reawoken, I think is probably the best way of describing it at that particular time. Feels like things have moved on as a generalised statement significantly since then. And what's in terms of the relationship between the NHS and local government and making a real success of that? I don't know what you think about some of the keys to that are.
I think it is back to respect and dialogue. I think there are sensitivities in local government, particularly when you start talking about population health. Public health has been one of those responsibilities that local government have had since it was returned to them in 2013. And I think there's an issue for them about their wider role as leaders of place and the fact that they have an accountability out to their population, whereas the NHS has an accountability that tends to be orientated upwards. And I think one of the tricks that those of us who are trying to act as facilitators and enablers of these partnerships have to pull off is to get the strength of both those forms of accountability to improve what we're trying to do in the here and now, whilst getting this sense of shared ambition, which actually, when you start talking about inclusive growth, you start talking about reducing inequalities and improving people's health in the long run, it excites councillors, it excites officers in local government, it gets people engaged in a way that they haven't been before. And I think that's the challenge. We all have to sort of begin to find a common language, a way of talking to each other. And once we start doing that, we actually find we have far more in common and a common agenda to pursue.
Well, and I don't know if Rob or Gemma want to come in on this thought, but I was speaking to a GP the other day who was saying to me, you've got to give people hope that they're doing the right thing. That if you want their energy and their commitment, you've got to back them up as leaders, but you've got to give them hope. How do we give people, and I'm talking about the people who are really going to drive change, the real practical changes, not the sort of just the very top leaders, but the people who are really going to make stuff happen. How do we give those people hope that this is real, that they're going to get backing, and that we are pursuing the right agenda on behalf of our communities? I don't know, Rob, do you want to come in on that one? Can I ask, or Gemma, can I ask you to come in on that one?
Yeah, absolutely. I think it's about getting the golden thread right within your local community and the STP. So I envisage it, and particularly within Herefordshire and Worcestershire, what we're trying to do is get a golden thread going from clinical directors up to geographical areas, so our locality areas, then up to our STP partnership board, and also with our other integrated partners within the system. So actually at every point somebody touches that golden thread that goes right from patient level to senior leadership level. And I think if you can achieve that sort of model within your STP area, you should always have the voices of the frontline clinicians that are representing the patients that will then inform the system and help support things moving forward. We spent a long time looking at the model of how we get that right sorted locally, and we've finally just got it sorted with the golden thread and a GP provider board that then works with other integrated parts of the system. So it's working well, but I would encourage people that haven't thought about that sort of level of operational sort of movement to do that and to go forward with it.
Yeah,
okay, so
I
Rob, do you want to come on?
So I agree with that, and I think it's got to be visible. I mean, that's the key thing. So you've got to be able to demonstrate that people have told you something's important and they want it to be better, and you demonstrate that you take it as something that's important and you make it better. So from a clinical perspective, we've got big things like how many hyperacute stroke units should we have? The national evidence said it should be 2 or 3. We haven't ended up with 2 or 3. We've ended up with 5. We've closed one and kept 5 because the outcomes are really good, and the quality of each of those units has gone up. In terms of vascular services, the clinical voices have worked on us moving from 3 vascular centres to 2, but creating a new model, which is a networked model, so everyone feels connected to it. In terms of assessment and treatment units, we've collectively agreed that we should move from 3 to 2. That's been clinically driven. So people are actively seeing their decisions being implemented. It's changing the conversation. One of the nicest examples, I think, is we know that cardiovascular disease is the biggest cause of death and disability in West Yorkshire and Harrogate, and we've got a really nice programme of work developed in Bradford, Healthy Hearts, and about 3 years ago we wanted to implement this and roll it out everywhere, and I think the other bits of West Yorkshire poo-pooed it. One cardiologist being heard to say not only was it invented in Bradford, but it was invented by a GP, and you expect me to do it. What we've done since we've had the integrated care system, since we've proven that we can adopt each other's practice, is that Healthy Hearts program's now being rolled out right across.
That's a great example, and I think I'm going to end it there, because I think this point about this is about partnerships, trust, and relationships. In the end, is going to be about results for people, and I think that's a great way to end. And really, thank you so much to Paul, Gemma, and Rob for sharing their perspectives. Thank you to all of you for joining, for contributing on the chat box. Can I just say the second of these webinars will take place on Wednesday, the 8th of April, when we will be talking about using the skills and strengths of communities to transform health and care services. We will be looking at some of the sound issues we've had, so hopefully we can do better on that one. And but please do join us on that, and we'll obviously be sharing the materials. But thank you very much for your time on such a busy period for the health and social care system. We do really appreciate it. Goodbye, everybody.
Thanks, Roger.